In this recording, I want to talk about the small bowel. We often refer to the study of the small bowel with contrast to small bowel follow-through. It often follows an upper GI, so sometimes you will have a esophagram, upper GI, small bowel follow-through all in the same, all in the same exam on the same patient. So what we do with a small bowel follow-through is that we fill the stomach up and then we watch it and take incremental x-rays until we get from the small bowel into the large intestine. So we can see a difference between the appearance of the small intestine and large intestine. So it's pretty obvious once the exam is complete. We're going to talk about the contrasts, the type of contrast when we're going to use different types of contrasts. And they follow the same rules that we've talked about before, but we're also going to talk about the procedure itself. We'll talk about the anatomy, but we'll talk about some pathologies as well. So anatomy review, the small intestine is really broken down into three portions, and that is the duodenum being the first portion of it, which is very, very short, and then the jejunum and the ileum. And I will show you where you can find each portion of the small intestine. So the duodenum comes directly off the stomach and is pretty much midline, and the distal portion, the very last portion, is the ileum, and that's what hooks up to the colon at what we refer to as the ileocecal valve. The ileocecal valve plugs into the colon just above the cecum of the colon, which is the portion of the colon that the vermiform appendix attaches to. So even though the appendix we generally don't talk about it in context of it being a digestive organ, it hangs off the bottom of the cecum, and that's how you remember where the ileocecal valve is, and therefore where a large portion of the ileum is on the patient's right hand side. So it extends from the pyloric sphincter to the ileocecal valve. It's about 22 feet long in adults, and it has those three parts to it. So the duodenum is the first portion. It's very short. It's only 8 to 10 inches long, and it's C-shaped. And the first portion of that is what we refer to as duodenal bulb. You can have a stricture at the duodenal bulb. It's not really a stricture, it's a atresia, and it is what we talked about previously in the esophagus. Atresia is incomplete esophagus, and with the duodenal atresia, then what we have is a pinched off duodenum, and nothing can get through there. There is another condition that we refer to as pyloric stenosis, where the pylorus is so scrunched down that nothing can get out of the stomach and into the duodenum. So where we see the duodenal bulb really well, unfortunately, is in a case of duodenal atresia. So then what we have is you can see an air-filled stomach, and then you can see a second structure that's air-filled, and that will be the duodenal bulb. And with that, what we get is what we refer to as a double bubble sign. So the portion that joins the jejunum, I'm going to let you stumble through that, and then the flexure is supported by a suspensory ligament, and that is what we call the ligament of Treitz. So the small intestine is kind of framed by the large intestine, so this is all small intestine here. Again, it starts right at the distal portion of the stomach, and it plugs into the ileocecal valve, into the cecum right over here, and then starts the large intestine. So the small intestine in this diagram it appears like it's very smooth. And if you ever see an open abdominal surgery, it kind of looks like that from the outside. But on the inside, you have all those little villi that are kind of feathery in appearance in x-rays. And I'll show you an x-ray here in a bit that they kind of show that. The outer portion truly is pretty smooth, like what you're seeing here. But once it gets into the barium gets into the colon, you'll see those haustral markings, those pouches. You'll be able to differentiate between the small intestine and the large intestine when the contrast gets to the large intestine. So again, with the colon removed, there's the villi. What we see here, though, is in the loop of duodenum, what we see is the head of the pancreas. And I'd mentioned in the previous recording that if the patient has a tumor in the head of the pancreas, then the head of the pancreas extends. So the C loop of duodenum gets very, very large. Also, though, what you see here is where the bile ducts empty into the small intestine in the duodenum. So we're going to talk about, when we get into the biliary system, we're going to talk about what this is and what these ducts in here are as well. We're going to talk about the entire biliary system. So this duct coming up and going into the liver, spreading out into individual ducts that go into the liver. So we'll get to that eventually. So quadrants, again, take a good history on the patient, find out where the patient's hurting, and remember there's two different ways to identify different portions of the patient's abdomen. That would be the quadrants, and quadrants we have 4. We have left upper, right upper, we have left lower and right lower. But if we need to identify something that's straight up and down the middle, for the most part we're going to use those regions. So this will be epigastric, umbilical, and hypogastric regions. And you can also use the hypochondriac regions and all those things as well. These most of the time will get you where you need to be. Oh, and backing it up, I apologize for that. The duodenum is in pretty much at midline, so you see it in both the right upper quadrant and left upper quadrant. The jejunum is in the left upper quadrant and the left lower quadrant, so that's the second portion over here. And then the last portion, the ileum, is primarily, it travels across the left lower quadrant, and the rest of it is in the right-hand side. The ileocecal valve is in the right lower quadrant. This little thing down here that you're seeing kind of suspended from the bottom of the colon, again, that's the cecum, and that would be the vermiform appendix. Same thing on x-rays. So our purpose or our function for the small intestine is digestion and absorption of food. So specifically, when we go back up to this diagram here, where we get the biliary tract emptying into here, we get pancreatic juices that come in here. What we get in this portion is emulsification of fat. Certainly we get digestion and absorption as well, but the emulsification of fat occurs because a lot of the bile comes in, bile, B-I, my East Texas accent. That sounds probably to most people outside of East Texas like I'm talking about a spherical object you throw over a plate playing baseball. Bile, B-I-L-E, comes through this little hole right here, and it emulsifies the fat so the patient can absorb it. All right, so technical considerations. Again, we need to understand the GI transit. We need to understand how long it's going to take for the contrast to get from the stomach into the colon through the ileocecal valve. We need to understand the procedure. We need to understand and use the appropriate contrast media. This could be a matter of life or death for the patient, or it could be a matter of whether or not how extensive their surgery may be, if they're headed for surgery. Preparation of the examination room, radiation exposure, and then radiation protection. For the most part, your radiation protection for the patient is going to be centering appropriately and using the proper technique. Exposure time, again, we need to keep it short because of the transit, the movement of the bowel. We don't want to introduce motion. Preparation of the examination room, I know I'm going backwards with this, preparation of the examination room, are to have those things that I spoke about in the last video available. So in this case, if you're just looking at the small intestine at this point, most of the time you're going to use thin barium, so it'll go through a whole lot faster. But if we have a suspected perforation, then we're going to want to use iodinated contrast. So one pathology that you'll see in the small intestine is what we refer to as a duodenal ulcer, and that's caused by a bacteria. And it can not just bleed, but it can perforate. And so the patient has a hole in their small intestine. And there are clinical signs for that. If you take a scalp x-ray on the patient and you see what appears to be free air, especially if you're upright and the patient has free air up under their diaphragm, that's a good indication that they've got to do a dental ulcer. So you certainly would not want to have a patient take barium. You would want to present that examination to the radiologist, send them that individual x-ray, and ask them if they want to use iodinated contrast at that point. So your procedure then is pretty much just going to be KUBs. So for that reason, most of the time, this is the first contrast study that you learn to do because it's just KUBs. There are some positioning variances. If you're just doing a small bowel follow through, then what you may do is you may have the patient drink the contrast, lay the patient down on the table, and your first examination or your first x-ray may not be for 15 minutes. And when you take that x-ray, then your centering is going to be more like you would center for an upright abdomen. And the reason for that is all the contrast is going to be in the patient's stomach. There's not going to be much contrast even into the jejunum. It's going to be in the stomach and the first part of the small intestine. So understanding GI transit, if you understand that it's going to take an hour and a half, maybe even 2 hours for the contrast to make it to the ileocecal valve, then you understand that you're going to have a patient for a little while. So because of the examination procedure in the GI transit, you're not going to be taking x-rays very often. So you may take a scalp, have the patient drink, take a 15-minute image, look at it, see where the contrast is, take another image in 15 minutes and another image every 15 minutes for the first hour, and then you may go to every 30 minutes after that until it reaches the ileocecal valve. Now, depending on what the patient's pathology is and the reason that we're doing a small bowel follow through, we might have images that we're doing 8 hours later. So if a patient has bowel obstruction, sometimes a barium is going to take a long time to get to the ileocecal valve. So average transit time to the ileocecal valve may be 2 hours, maybe 3 hours. It may be more than that. Some of your patients may get there pretty quickly in an hour and a half. Some of your patients might even exceed that. So to get there faster than that. So peristalsis, again, is just like in the esophagus, it's contraction waves. So contrast media, we've kind of done that to death, so I'm not going to stop on that. The iodinated contrast, just make sure two things that you understand. One is if the patient, you know the patient is most likely going to surgery, iodinated contrast is the contrast you want to use, unless specifically ordered otherwise. If you're doing double contrast, you cannot do that with iodinated contrast. Also, though, if the patient is allergic to iodine, that's a very important thing for you to ask the patient. If they're allergic to iodine, if they have medication allergies, you need to know that before you give the patient iodinated contrast. So preparation of the examination room really depends on what you're doing. If you're doing the full gamut, if you're doing esophagram, upper GI, small bowel follow through, then you're going to have the table set up with the footboard on. Make sure you have plenty of image receptors if you're using CR. If you're using DR, of course, you're just going to use the same one over and over again. Preparation of the contrast, but if you're just doing small bowel follow through, chances are you're just going to be using thin barium, and you don't have to have the table upright. You're not going to be doing any drinking exams. You can have the patient sit up on the side of the table, drink the contrast, lay down, and then it's just a matter of taking the x-rays until it reaches the ileocecal valve. Again, describe the taste of the contrast to the patient and don't lie to them. Really recommend that you take a sip of it so that you can give them a true assessment of what it tastes like. Because if you just tell a patient it's not all that bad and then you give them iodinated contrast, then again, you're going to show yourself to be a liar. It is awful. It's really bad. The barium is not as bad, but it's real chalky. So it's kind of like flavored chalk. as opposed to the iodinated contrast. It tastes like a dirty trash can. You put a little bit of water in it, stirred it around, and then gave it to somebody to drink. It's pretty disgusting. So the enema tip insertion obviously does not have a place here. So exposure time, keep it short because of peristalsis. We've done that. To death, radiation protection, again, just close collimation and good technical factors. So we can do this in a number of different ways. So what we can do with the small intestine procedure is have a patient drink, and that's the preferred way. If the patient can't drink for whatever reason, then we can do a direct injection into the small intestine. And we've got a couple of things there. This says that is termed enterocolysis, and that's not entirely true. You can do just a regular small bowel through what we refer to as an NG tube. So an NG tube stands for nasogastric tube. It goes through the nose, down the throat, into the stomach, and you can just push regular barium into it. Specifically, what an enterocolysis is a double contrast examination of the small intestine. So what we have with enterocolysis are two different types of things. So we've got a barium suspension that we push through the NG tube. And in this case, the NG tube may be something more like a Dobhoff or some sort of NG tube that goes all the way through the stomach into the small intestine. Then what you're going to do is you're going to alternate the injection of the barium with a different medication. It's called methylcellulose. What that gives us is a double contrast exam of the small intestine, or at least a portion of it. By the time it gets all the way down to the ileum, the last portion of the small intestine, you might lose some of that double contrast and it just looks like a regular small bowel follow through. So the oral method is most common. The least common would be your reflux filling, and that's where you would give the patient a barium enema, and what they would try to do is get filling from the large intestine back into the small intestine at the ileocecal valve. Try to get it. They may have to massage it with a compression device, a palparian, to try to get it to come back up into the small intestine. I've never seen that procedure intentionally done. I have seen failure of the ileocecal valve, so that we were doing, in this case, it was gastrographing the enema on a patient, where it got to the ileocecal valve and completely filled the colon up, and the ileocecal valve was wide open, and the contrast went all the way back up, all the way through the stomach and into the esophagus. So it can be done reflux, but I've just never seen it done intentionally, just that one time on really entirely on accident. So patient prep, patient needs to have a low residual diet for 2 days before the study, and then food and fluid should be withheld after the evening meal. About the only thing the patient should do after the evening meal is maybe brush your teeth. So some of your hospitals, some of your doctors are pretty particular, and they may have a patient do a cleansing enema on the day of the exam in order to clean them out a little bit more. So the oral method, again, is a small bowel series, and what we're going to do is we're going to make the exposures, and we're going to identify each exposure with a marker so that the doctor can tell exactly how far apart those images were and assess the time interval so that they can assess the transit and how long it takes to get to the ileocecal valve. Patient body position doesn't really matter if you take the x-rays with patient supine or prone. There are some benefits to each, but really for my experience, the patient comfort is really the most important thing. And in most cases, your patients are going to be more comfortable laying on their back as opposed to on their stomach. Now, there are times that you may want to flip the patient over onto their stomach, specifically whenever you're trying to spot the ileocecal valve. You may want the patient to lay on their stomach on a palparian or some sort of compression device in order to visualize that a whole lot better. So again, just your order of operation. First image is taken 15 minutes after ingestion of the barium. The next is going to be about 15 minutes later. If it just looks like it didn't move at all and on the first 15-minute image, then your radiologist may ask for 30 minutes. So the radiologist should take a look at each one, but they may ask you just to present all of the images to them the after the barium reaches the ileocecal valve. Of course, if you have a patient where the barium is moving really, really slow, then the radiologist is going to need to see that anyway. So typically after a couple of hours, then we should see some spillage over into the colon at that point. We talked about the reflux examination, enterocolitis, it's direct injection, and again, that's going to be alternating with barium and methylcellulose through NG tube or some sort of duodenal tube. Small bowel procedures, enterocolitis, just more of the same thing. Contraindications, if the patient's pre-surgical, or if the patient has some sort of obstruction and you don't think that the barium is going to go through, especially in the colon. If they think that the obstruction is in the colon, the purpose for the colon is to extract fluid. And if you have a patient who has a large bowel obstruction in the colon, then what can happen is the barium can get into the colon and the water is reabsorbed out of the barium suspension, and the barium pretty much sets up like concrete. So take a history on the patient, try to find out what's going on with the patient, and then present that to the radiologist. And certainly, again, if the patient has some sort of perforation of the small intestine, you don't want to give them barium. You want to give them iodinated contrast. But some considerations for the patient is that if they are dehydrated, the water soluble acts as if it is a laxative and it can further dehydrate the patient. So young patients or older patients are more prone to dehydration. And again, I already talked about the sensitivity to iodine. So just more of the same stuff, really. So PA projection, again, your first image is going to be high instead of being as if we are taking a KUB. What we're going to do is we're going to center about 2 inches above the iliac crest, put the top of the image receptor pretty much at the level of the axilla, because the only thing that we're looking for at that point is going to be barium in the stomach. Everything else after that, the central ray should be to the iliac crest. So we want to see evidence of proper collimation. You want to see the entire intestine on each image with the possible exception of the first one. You want the marker, a time marker, and then you want the vertebra to be in the center. There are no obliques here potentially until we get to the ileocecal valve. So we don't want any kind of rotation. Exposure technique should show the anatomy but without any kind of motion. So you want that short exposure time. And then that's what they look like. So we've got a lot of stuff going on here. So again, the first image is going to be your scalp. So on a lot of the contrast exams that we're going to talk about scalp radiograph. A scalp radiograph is an x-ray that you take before you give the patient any kind of contrast so that you can see the general location and the size of the anatomy that you're going to be looking for. So scalp radiograph is the first exam that you take, and it should be representative of most of the exams, most of the images that you're going to take. So this thing is kind of interesting. So what we've got is parasitic roundworm, and that's that thing that we're seeing right there. So that's probably the cause of this patient's discomfort, is they've got a great big roundworm. Probably a lot of cramping there. So 30 minutes, this is almost an extreme case. So we've got one of two different things going on here. This is colon here. So our ileocecal valve, it looks like that's probably it right there. But we've got colon here. All of this is small intestine. You notice the first portion of the small intestine is kind of feathery. And then this down here all the way into the jejunum and eventually the ileum. We've got what just looks like just a glob of contrast. So at 30 minutes, if we're already in the colon, that's pretty quick. You just don't see that a whole lot. So we've got one of two different things going on. So Spoiler alert for the next video where I talk about barium minimus is that if we're doing a full barium study on the patient, that would be an esophagram, upper GI, small bowel follow through, barium enema, then our order of operation is going to change a little bit. So what we're going to do first then is going to be the barium enema, because the last image on barium enema is an image where the patient has evacuated the bowels and they've gotten rid of as much of the contrast as they possibly can. And then we can see as much of the small intestine as we can. We're going to see some obvious residual barium in the colon, but it's not going to be as bad as trying to wait for all this contrast to go through and give us a good colonic study. So in that case, what we would do is we would do the barium enema first, evacuate the patient. That is to have the patient go to the restroom and evacuate their bowels, and then we would do the esophagram, upper GI, small bowel follow through. So just more of the same, 30 minutes to 1 hour. I assume, because these came out of the same textbook, that these are the same patient. Whenever we do a spot for the ileocecal valve, we're going to use fluoroscopy in a lot of cases. And so you can use this compression device to mash down onto the patient. You're not, you're not going to hang off this thing and really mash the patient real hard, but you can use that to compress the bowel to try to move things out of the way so that you can see the ileocecal valve. Or you can flip the patient over and shoot them prone with that compression device, the palparium. So again, ileocecal valve is here, very well delineated there. You just don't see it that well in a lot of cases. I would almost want to believe, because of the lack of contrast in the small intestine, that this is actually reflux filling of the ileum. I don't know that to be true, but that's kind of what it looks like to me. So post-exam procedures, tell the patient what to expect. That barium is going to come out of the patient looking just like it went in. So don't digest it. They've been in PO. Their bowels should be pretty well empty. So it goes in white, it comes out white. And what we need to do is we need to tell the patient to push fluids. And that is because the patient arrives somewhat dehydrated. So with them coming in dehydrated, if we put barium into the patient and that barium suspension gets down into the colon, the purpose for the colon is to reabsorb water. So it's going to try to pull water from that barium suspension. And again, if it pulls enough out, then what we're going to have is constipation, possibly constipation so bad the patient's going to need surgery to get that barium out. When barium dries, it dries like cement. And then the iodinated contrast, we tend to focus on barium, but we tend to neglect iodinated contrast in post-patient exam. So the iodinated contrast has a laxative effect. So it's going to make the patient need to evacuate their bowels because it's going to draw fluid into the lumen of the colon. And what that's going to do is going to lead to further dehydration. So your patient is going to come to you dehydrated, and if you give them iodinated contrast, they're going to leave and they're going to be more dehydrated. So and that could be a potentially bad situation for your elderly and your young patients. So we talked about the enterocolitis and what it is. Basically, is a double contrast study of the small intestine. So the purposes or the things that we might do the enterocolitis for would be some of the same things that we would do a small bowel study for. And that is small bowel obstruction, that's ileus. So again, we've got obstructive ileus, and we've got non-obstructive ileus. So small bowel obstruction. Crohn's disease, which is an autoimmune disease, it gives us a cobblestone appearance in our small intestine, and then we've got malabsorption syndrome. So any of those could be a purpose for doing a enterocolitis. So enterocolitis, if you look, you can see the feathery appearance of the small intestine. On your basic small bowel, you just don't see that all that well. I've already described all of this, so I'm not going to go back through it, but that's what an enterocolitis does, is gives us that double contrast appearance of the small intestine that you just can't get with just ingestion of barium. So pathologies that we're going to be looking at for small bowel studies, the blue, the things I've got marked in blue here, I don't have any images for, just because on a small bowel image, you just don't see them all that well. So clinical correlation, blood work and things like that are good for helping to diagnose those things. So we're going to focus on the other things. So we've got pyloric stenosis, and I described that earlier, and I'm going to show that to you here in a minute. Duodenal ulcers, again, the danger in a duodenal ulcer is whether or not it's perforated. Has the duodenum been perforated? Do we have an open cavity or an open passageway into the peritoneal cavity? Obstructions, for our purposes, we're not really going to distinguish between a actual obstruction and a paralytic ileus. For our purposes, they really don't look all that different. And then we've got Crohn's disease and a Meckel's diverticulum. So this is pyloric stenosis. Notice the stomach is great big. In this case, we've got none of the air is going from the stomach into the pylorus, into the duodenum, or through the pylorus into the duodenum. So what that means is that we've got total occlusion of the pylorus. So our stenosis, we've just got nothing going through there. Now, I'd mentioned earlier duodenal atresia, and what that's going to look like is you've got this here. That, this is not a double bubble sign. This is just the stomach, and we've got that indentation going on there. If I had another bubble way down here, then that would be your double bubble sign. And even though they may superimpose each other, one may be stacked on top of the other, you can still differentiate between the two. So the double bubble sign gives us an indication that we've got a duodenal atresia as opposed to pyloric stenosis. The clinical correlation for really either one of those is the baby, and this is a congenital condition in both cases, so the baby drinks the berry, or let's say the milk. This is clinical correlation. So a baby drinks the milk, and the milk settles in the stomach, sours, and then the patient projectile vomits it back up. So you may think, well, how do you distinguish that from esophageal atresia? Well, esophageal atresia comes directly back up. There's almost no barium or no milk taken in, and it comes directly back up. It just doesn't have anywhere to go, as opposed to with pyloric stenosis, it'll go down into the stomach. The stomach may fill as much as it can with all this air in there, and then eventually it's going to come out, and you don't want to be in front of it because it's going to be projectile vomiting. So we've got a duodenal ulcer here. Again, this is kind of double contrast extending into the small intestine. This is a small bowel obstruction. Whether or not it's an actual obstruction or if it's a paralytic ileus, it just doesn't matter to us. What we get is this stair-step appearance or step ladder appearance. It looks like you've got individual rungs on a ladder. And the telltale sign of any kind of bowel obstruction is that if we were to do a decubitus image on the patient, what we're going to see are air fluid levels. So in this case, this patient, if we stood this patient up, we would see air fluid levels. If we were to do a decubitus abdomen, horizontal central ray, we would see air fluid levels on this patient as well. What's causing this bowel obstruction? I don't know. If it's a non-obstruct ileus, it could be because the patient had surgery and the bowels just hadn't started moving yet. If you've ever had surgery, then what you know is that before they release you from the hospital, you got to go to the bathroom, or you've at least got to pass gas. which is just horrifying to some patients for the nursing staff to come in and ask you. And that's to make sure that the bowel is moving again. So if it's a non-obstructed ileus, it could be because of surgery, it could be because of pain. If you are a mom, if you've had a baby, then what you feel during labor sometimes is a little bit of abdominal pain that doesn't really seem to be related to the baby. You've got the back pain, you've got the labor pain, but all of a sudden you get a little bit of a belly pain, and that is because you've got an ileus, most likely. So moms, if you're not a mom yet, be looking forward to that. And if you have a mom, then on your birthday you really should be celebrating what your mom had to go through to bring you into this world, really more so than your contribution, which you don't even remember. So non-obstructed ileus can be caused by pain, it can be caused by drugs, pain medication, or anesthesia, or surgery, or any of those things. Mechanical bowel obstruction is totally different. It could be because of a cancer, it could be because of a twisting of the bowel, and that's the visualization of that is what we refer to as a bird beak sign, and what we call that is a volvulus. And also another thing that we can have, and usually this is in the colon, is what we refer to as intussusception, and that's where a portion of the bowel slides inside of itself. This is the appearance of Crohn's, and that is that cobblestone appearance that I spoke of before. So if you've ever been to a city that has kind of a historic district where they try to make the area look like it did in the 1700s, like say Philadelphia, then you know what a cobblestone street looks like, and that's what that is supposed to resemble, is cobblestones. So this is an interesting case here that I have no direct experience with. This is giardiasis, is how you pronounce that. Sorry for stumbling over that, but it's caused by a parasite that's a duodenal parasite, and it occurs from drinking contaminated fresh water. That's contaminated. It's not that common, but it does appear in patients who do a lot of hiking and camping and things like that, and they drink the water where they are, or they have been swimming in water, especially if the water is dammed up by beaver dams. So sometimes they refer to this, I think it's beaver fever is what they call it. So they associate it with the presence of beavers and activity in beavers in places where the patient has been exposed to the water. Meckel's diverticulum is something that you might run into, but it's pretty rare. And Meckel's diverticulum is almost like the body is trying to complete a vestigial organ out of place. So it's kind of like an ectopic vestigial organ. So what you may see then, and this is a example, I don't know that I've ever seen one in clinical, in my clinical experience, but this is what we're looking at here. So it's going to be just proximal to the ileocecal valve, and what can happen in these cases is that if this thing takes on the characteristics of the stomach, is the patient may have something like a gastric or a peptic ulcer inside of this Meckel's diverticulum. So it's not as common as what we want to make it out to be. Every textbook is going to cover Meckel's diverticulum like it's pretty prevalent. And if you do some research on it, what you find is that the prevalence is quite low, and in a lot of cases the discovery that the patient has Meckel's diverticulum is incidental, and it goes by what they refer to as the rule of twos. And this is is pretty extensive, and I'm not going to remember all of them, but it's like 2% of the population have a Meckel's diverticulum. And in those 2% of the population, 2% of those people are going to be symptomatic of having a Meckel's diverticulum. And it just goes on and on with these twos. So Meckel's diverticulum, again, is going to be just proximal to the ileocecal valve. So it's going to be very distal portion of the ileum. And it's just, as the name indicates, it's Meckel's diverticulum. So that is the end of small intestine. And next up will be large intestine, perio minima, everybody's favorite. That was sarcasm, by the way.